Friends and colleagues, welcome to this very webinar. This is the NAFLD Web Series 3 webinar. This is being hosted by Hope Initiative, Indian National Association for the Study. Many of you would have our first two sessions, and the whole series is actually of this series is Dr. Arun, Richmond, Virginia, in the United States. That he is one of the most eminent luminaries non-alcoholic fatty liver disease in the world. So he is here with us today to share the session or co-chair the session with my one-time teacher, mentor, Dr. Abraham. Welcome. And we have four. So we have Dr. Murugan. In the south, we have Dr. Vivek Saraswat and Dr. Krishna Das from. So before we Arun Sanyal on the screen, we have two other speakers. We have Dr. and Dr. Ajay Duseja. So a few of us here, we'll have about 1 and with us, and it will be basically a discussion. Before we go further, with you that we had a tragic loss. Lost Professor Rakesh. He was at the All India Institute of Medical Science. Obviously has taught many of us, established or senior gaps, and in honor to him and his memory, may I Saraswat to say a few words.
Professor Chowdhury, good afternoon. It's with a sad and a heavy. We remember our mentor, Rakesh Kumar Tandon, who in the first week of August this year. Dr. was he a former head of the nephrology at the All India Institute of Medical Science, also a past president of the Indian Society of, a founder member of the Indian Pancreas, and with a list of achievements to enumerate in these couple of minutes. I had the good fortune to be doing my first dissertation topic, DM, and an extremely approachable person. Felt as though you were in the presence of a distinguished teacher to interact with him. I owe interest in pancreatic diseases, lithiasis, and in procedure of ERCP. The teacher of 30 alumni who have walked out of the portals of the All India Institute, and for him with great fondness, with great, and his passing away almost hope as though somebody of our immediate body, very near and dear, had passed. And we hope to carry his further onwards the way he taught us.
Thank you. Just to mention that, you know, when we started conclave, I remember it was the NAFLD conclave 4. And, in the first two, we have having him to inaugurate also. He's obviously been very close to us. Now, let his soul rest in peace. Our
have a word,
yes, yeah.
I remember Professor Rakesh Tandon. He was my. I want to say something personal. I was joined for DM. There was a nation strike, and there was a looming railway, and I was going to get married. And DM Tandon and almost unapproachable. So then Rakesh came and told Dr. Koshi, Koshi, not Dr. Koshi, Koshi, you just go, leave. I'll take care of everything. And he did. And now I'm here. So to him, I would say, great life. in every way else, he was personal to me. So thank you, Rakesh, for everything.
Thank you very much. Personal attributes, apart from the encourage and stimulate many of us gastroenterology and do fields. Thank you very much. Go back to the normal view. Thank you. Yeah, fine. Pleasure and introducing Dr. Abraham Koshi, whom you have just, some of us are going to be the so-called this discussion and the mention, but our first Arun Sanyal, may I request Samir or Vivek to introduce Arun and us through 3 cases.
Dr. Samir. Samir.
Vivek, you are good at introducing.
Thank you, Samir. Hi, Arun. How are things?
Good, good.
Well,
Can I go back a very long
not to AB2 wards, E2 and D2 wards. During our well, even before that, we share the same Maulana Azad Medical College in Delhi, a year or so ahead of and when we moved to do our MD at the All India Institute, he was that bright maniac, absolutely. He and talking to everybody, and some of the most messages of presentation used to present to Dr. J.S. Bajaj. So another BN clone or from the same mold, a very tough guy, and to him was one of the best things you aspired to do during your. Well, soon after we finished MD, I think across the 7 seas to Virginia, and then heights that we here in India. And a lot of it is due to the personal attributes, his heart, his intellect, and also he didn't have to hang around after MD and gastro in India. I think he found as one of the past presidents. There are very few honors and Arun hasn't accumulated during his career, and now I think starting off with diabetes in Dr. J.S. Bajaj, interest in the insulin clamp and metabolism has stayed with him, and him leading the global the US, the CRN in the US. So with these few words, Arun, I think to the case presentation, moving on with the program.
Well, thank you for those very kind words. Dr. Saraswat, we started our DM together, very close by where we used to live. Me up on his motorcycle. One of the best conversations happened on our way to All India Institute. And we were always get there in time because you did please Dr. Bajaj for sure. Also a little bit of an ego battle. Wanted to make sure that he could not find guys. So we kept upping the. But I think in the long term, that approach really who we are as individuals continuously push for X. And I got to say, we've all become very politically correct. And in the process, which is good, sometimes things were a little extreme, but we've done something along the way, not having any somewhere there has to be a sweet spot. With that, again, talking of sweet spot, actually personify, able to balance other life and work, whereas mentors were very work. So I would this session, Rakesh, and his memory. Should we get started?
Yes.
So move to the next slide. Good. Let me minimize over here, put it up in the corner. Now we can start. So let's today. The patient is, she's 58 years old, lady, recent year. She visits a gastroenterologist, as has some upper abdominal discomfort. She has a history of not a smoker, does not drink alcohol, history of drug use or blood transfusion. This is not really related. I'll give you some, not related to bowel movement. There's no clear food so typically you would associate with ulcer disease. She's married to Foreman and Losartan. Her BMI is 28. There's mild hepatomegaly, but there's really a physical exam that jumps up. So she's not anemic. There are no. I'll just give you that. None of the warning for that would warrant right away. Since the patient over here, she is surface antibody are slightly elevated at 48 for ALT and AST. Her surface antibody, core hepatitis C, and she also on the panel, her GGT is elevated. Her lipid profile is provided. So let's go to the next. So let's be fairly straightforward over here. The next best test is urine alcohol level, fibroscan, or an MRI PDI estimation. You go ahead and poll answer in your polling panel side of the video, please. About 15 seconds, can you show us what the results are? Oh, good. So the majority of people pick. So let's talk about. Okay, can you take us back to the question slide? Okay. So over here, the ALT, the patient's cultural background, etc. Although you can be fooled by that, at least by history, there's no real indicate that alcohol is an issue. Probably for me, the fact is higher than the AST suggests that clinical excess alcohol use is probably not a major issue here. HCV, PCR in someone who does not for hepatitis C or is not immunosuppressed, which is the antibody could be negative. It gives you the same sensitivity as a not much value in PCR if the antibody is negative. Between PDFF, the main issue that PDFF can tell you, but it doesn't necessarily tell you if liver stiffness is. The two pieces of information here, probability given her hypertension that she's got a little bit of and also that she's by Asian standards obese and at least overweight by global. She has multiple risks, non-alcoholic fatty liver disease. In that setting, you want to know both, how much fat there is, whether you're scarring, and so you need to know assessment of liver stiffness as well. The next slide, please. So there are a few teaching points to this. So two principal things you need to keep in mind when diagnosis. You need to ask yourself, trying to rule something out, to rule something in. You can see over here, if you take rho, which is 1 to 3, this is continuous attenuation parameter. It tells you how quickly the amplitude waves are attenuated. It passes through the liver. To separate from no fat, you have an overall R 0.78, so completely perfect. But the positive predictive value appeared over here. But the point here is that the value in that empty, that is really with a cutoff of about 300, really sensitivity well over 90%. So you can actually, with confidence, with positive predictive, the presence of fat. It's not that able to present diagnosing whether it is stage, because as you can see, both the predictive values deteriorate, separate the difference in steatosis. Next slide, please. Here we are. So the cutoffs, the original cutoff, the positive predictive value is 90. If you raise that to about 300, it drops 80%, and actually specificity quite a bit as well. And here, the sensitivity is, but the specificity really is. So for this test is if you take a threshold, anything above 270 to you can, if it, you can say with confidence, yes, there. Next slide. And here is the other piece of, which tells you how stiff the liver fibroscan. Now, remember, surrounded by Glissen's capsule. Stiffness is a measure of that capsule with liver tissue. So the make that tightness is, one is the amount of liver tissue. Number two, the blood in the liver at any given time. So heart failure, you basically have an engorged very liver, which really is tight the Glissen's capsule from and makes the liver more tight. If you have severe backup of bile, the same, but very importantly, very inflamed, and the total liver because of inflammation is, that also can make the liver. So with all those caveats, this is not really a pure measure of, because in the setting of NASH, because also inflammation involved. See that compared to stage 0, stage 4, very nice. Between there's considerable overlap in stages. Next slide. And so there have been attempts on trying to identify how much there is, but really to try to identify if the patient has NASH with stage 2 or higher. Now that is a profile that we just risk NASH. At risk, why? They are at risk of actually having outcome. And so that you think you might give a pharmacology. And so this is the, and you can see what this does. It adds not only liver stiffness, but the AS formula that you can put in, and then that gives you a score. Essentially, the FAST score looked at, and this is still in evidence, but it looks promising as only identify how much fat and stuff, but actually to nail down what's called clinically significant NASH, risk NASH, which is fatty liver with fibrosis stage 2 or higher, activity of 4 or. Next slide, please. Okay, so additional information here. So patient did get a fibrosis and CAP is 300 and the liver stiffness is 9. Next slide. So what is the most likely? Let's poll.
No, one is showing this needs to be the question.
Yeah, here you go. Page 2. Okay. So most people thought there's a good here, but worth talking about. People got 45, 50. That's stage 2. That would be the conventional thinking. All right. Here I made it a little, this was a question. So conventionally, that's what. So next slide. So the biopsy is actually done. As you can see, there's almost much going on. It's a fat, there's a little bit, and unfortunately I do not here, so I cannot show you the exact blue. There's a little bit of ballooning. If you go directly south of blood vessel, which is in the left of center of this, you will see a few rare and a few cells under. Anyway, so there is steatohepatitis, really see significant fibrosis. So what happened? So next question. What is the cause of disconnect biopsy and the fibroscan? Assessment is incorrect. It's useless technology. Is useless, doesn't know how to do a fibroscan. Or the doctor is useless, doesn't know how to do a scan. I thought it's time to sort of think. Okay, good. So you see, we are equally split with the physician and good. I just want to put a caveat. Some are wrong answer. They're just different answers. The point of all of this is not to say this, but to really have a conversation. These different issues. Okay, so why what would be the basis for this disconnect? Ultimate teaching point from this. Many of us are familiar with fibroscan. Anything above 8, we start thinking stage 2 or higher. Above 10, thinking about bridging fibrosis. Above thinking about cirrhosis. So those thresholds commonly used in clinical practice. Next slide, please. The point is this. This is probably a teaching point to remember. There is something called a pretest Pretest probability means before we do the test, what is the patient has, what you are looking at. So if you go into a population and has the disease, then no matter how good or bad it is, will always be, you're only testing it in positive people. Similarly, if nobody has the disease, the test will be negative in everybody. So there is something called Bayesian theory says that your predictive power is inversely related to your prevalence. If you have a low prevalence and have in that setting, if you find a positive test, it's likely to be a false positive test. And in a high prevalence, if you have a negative test, it will be a negative test. So you think about what setting you are running. And that's why I emphasized earlier, this patient is actually being seen by a GP is referring the patient to of the imaging centers in the. This is not being done in the hepatologist's office. Hepatologist's office, you're much more to predictive value because it's for people with more disease, simply because it's known as ascertainment bias. It's the that you see. If it's general clinic, the prevalence of disease is much lower, so you have a possibility of actually making false positives. Now, if you go back, you talked about high sensitivity, but the specificity for fibrosis is quite modest in the 0.3 range. So certainly to low prevalence situations, you have to be of the possibility that you might overcalling the diagnosis present. And that's really just a teaching point at the back of our minds. So that was the. I'll stop here and take a few questions. On to the next case. Slide behind this. So this is basically the point. Interpretation of diagnostic tests. One size does not fit all. It's diagnostic tests, and so something you might want to keep in mind. People would call it stage 2, which is what.
Yeah, but if the moderator, can I ask a question?
Please.
Arun, in a very important learning lesson, a lot of reports coming with F4 fibrosis. Person has had congestive cardiac failure, and when they have improved to normal, and therefore what I have started doing is not F but writing stiff.
Yeah.
So a little increase rather than actually committing yourself to. What are your views on that?
Completely agree. Could not agree more. I think because hepatology as a evolved from pathology like Hans Popper, etc. We have always lived in a historical way of thinking about how we take it. And certainly over the years, it has become very clear. Logical assessment is mired with and anchor. Histology is a surrogate for telling the risk of dying and what's going on. And so, as we develop strategies for evaluating invasively more easily, so they don't have to go into a hospital, get additional testing done, etc. We need to link outcome profiles of these directly to the rather than to an intermediate reference standard of, and so continuously improve the field. We need to keep it to outcomes rather than histology.
I think Arun, there is a from Dr. Rakesh from He wants to know whether the steatosis 262 300 that you mentioned on the should be different depending on body habits in different geographical regions. You would have one fixed cutoff, normal, abnormal.
So habits should not make any difference because, from Hong Kong suggests habitus may make a difference, and it would be valuable to generate those data to be able to actually low-hanging fruit for to take the last 5 scans done, especially if there's a biopsy to it. This may be something that ICON D, for example, to establish Indian norms. You know, it's not precision science of Mars orbiter. You know, you just want to land in a general ball. Anywhere between 275 and sort of gets you there. These thresholds are not. And what we find is that for most of our patients have well over that number. It's
Right.
really not a diagnostic conundrum. In terms of the lower end, probably generate some India-specific data. It may already exist that I'm not aware of. No.
Yeah. Continuation with this, I think Dr. Rakesh asking that could this disconnect sampling error? You know that biopsy error and the fibrosis may be patchy.
Fibrosis is never that patchy. It's always risk of one stage difference is about 40%. Stage difference is 5%. So yes, possible, but very unlikely. Nothing. So you know, one stage difference, but it's to have nothing in one versus fibrosis on another biopsy. Just a priori, statistically, it's less likely.
That is an adequate biopsy. Take the next one of course.
Yeah,
So,
there's somebody who wants to say that biopsy misses cirrhosis in 20%. You end up calling it stage 3. Rarely stage 2, but you will no fibrosis. So yes, histology is, of course, that's what we all. Histology is imperfect, and that these non-invasive tests rather than to histology. But it is likely that you will get tests are very good for polar extreme, all of them. So it's unlikely that.
So Arun, that for a primary care physician or a specialist, it would be worthwhile to do, because if the FIB4 is, then he need not go for a fibroscan in the first place.
I know, I completely agree. And FIB4 is something that doesn't cost. It's part of the basic labs. And FIB4 with outcome. And so I think it's definitely they're setting a important part of the assessment. FIB4 only tells you, but it doesn't necessarily give you, pretest probability is very high. Essentially, if the FIB4 is low, below likelihood of having significant fibrosis less than 10%. So a few 6 months trying to work on weight loss, optimization of the metabolic status before additional testing.
Sure.
Okay.
I think we can go.
I think there was a question about biopsy in 20%. That is true, but it calls it bridging fibrosis more than cirrhosis. MRE, 2D MRE is debunked. There's a lot of MRE. It is not the precision tool that people used to think it was, and is more expensive toaster. Next slide. So patient is Mr. C. He is for telecom, has got multiple hypertension, dyslipidemia. In the evening, he likes drinks, but not really. But he has some social. There's no history of drug use, blood transfusion, low back pain. He's referred now as a gastroenterologist for abnormal liver enzyme. Background medications. He's on a statin. His BMI is also 28. Hepatomegaly. Profile is shown over here. He has a core antibody that's HCV is negative. AST is 60. ALT is. His LDL cholesterol, triglycerides are 220. HDL is a little low. He has a cap of 310 and his liver is 11. Okay, next. So he is then, based on this, that this physician thinks, significant increased liver stiffness, evidence of fat in his liver. Can you go back? So over here, he already, sartans are covered, statins are, but he still, as you notice, still has high. Statins do not affect triglycerides, and statins don't improve HDL. So saroglitazar improves both of them. And then OCA also improves, although it can reduce HDL. So he's there on saroglitazar and OCA, thinking that this will improve his and his liver disease. Next. Go back. So the question go. I thought I had a. Okay, so we'll come to the question here that saroglitazar reduces triglycerides. Data from a phase 2 study. Also, it increases really the basis for how you, for next. Your total cholesterol comes down and your LDL cholesterol, particularly at 4 mg. That's the right dose to use. Next. And if you look at OC, it will increase your cholesterol, your triglycerides do, but your comes down a little bit, and your LDL. So OCA doesn't really have a great on serum lipids. And the slides are backwards. Thinking, answer away. So anyway, the question was, how many people still get interesting to watch? Following is correct regarding saroglitazar on lipids. Saroglitazar is HDL cholesterol, but HDL cholesterol both increase. OCA increases LDL, both decrease. Oh, let's see the answer again. No, that's the wrong question. Great. So good. All right. So 20. Wow, almost 25 people still got it wrong. So go back and review that one more time. Back 2 slides. One more. Yeah, here. Okay, just so if you look at this slide, the effect of saroglitazar on the. So if you see placebo is in blue, saroglitazar 1 milligram, 2 milligram are shown, and what you see, just focus on the green bar. Significant drop in triglyceride by almost 2 grams. HDL between, almost 12 milligrams. And this is very important because it does not improve HDL cholesterol. It affects LDL. And this is an important differentiator. And if you look at total cholesterol, again, you're seeing it come down, and the LDL improves with saroglitazar. Saroglitazar improves different Next slide. And when you look at what you see here is in orange is shown the placebo, and in blue is shown the OCA. And what you see is going from the top, left to right, total cholesterol is increased, decreased. So both saroglitazar and triglycerides, the H, if you look at the lower left, is decreased. And then LDL goes. So this is a big difference. That saroglitazar actually HDL and decreases, and OCA does. OCA decreases HDL, LDL. So when you give OCA, to intensify you have to keep the cholesterol levels and intensify the statin therapy, not statins, to make your LDL doesn't rise in age, and but improve your statin, your HDL. So you still figure out what you're going to do with the HDL. In general, patients with NASH, increase in cardiovascular risk, all causes of mortality, the driver of mortality. Those are the important of this case. Think beyond the liver you're doing to your patient. And really, the point is not whether this patient or on OCA or not something else. The point was that these are approved in India that are being used. You have to know what these drugs do, but beyond the liver, you have to treat the patient. So that's really what I was trying. So I'll take some questions now. Wait, I have some additional points I want to make. Keep going. So now the patient comes back 1 month later. I've been very nauseous, a little feverish, but I have no fever. I haven't changed. I'm just very nauseous. I just don't feel. And my urine looks a little. And so. So the doctor, on this and says, well, patients with COVID-19 symptoms, I'll test you for COVID is negative. You see here, platelets have dropped a little bit. AST is now 150. jump to 210. Alpha bilirubin is 1. Iron 1. Okay. He started with AST-ALT in the next slide. So the next most step is to all potential of CA saroglitazar statin, ultrasound, repeat lab 48 to 72 hours, the patient and continue therapy. This type of ALT change is common. Let's a lot of people would reassure the patient going. Okay. Okay, very interesting. Okay. As I said, you know, there's no right or wrong. Just different ways you approach it. This and what the teaching points will be. Question is, medicine is to do no harm. Nocere. So which means do no harm. So do no harm that you give should not be producing it. And something at least in the US, only in the people have become much more sensitized to is the possibility an acute flare in enzymes a patient that one of their this. Now when most of the literature on liver injury comes from in studies where people for non-liver diseases with a liver start with, and then you're started and then suddenly the liver becomes abnormal. When you go from someone who has no liver suddenly develop acute liver injury after you start a drug. But the problem is injury with AST-ALT bilirubin. But these are already abnormal chronic liver disease. So go up. A question that always should come is this due to the liver disease or is this because you need to know the natural history of enzymes in the context of the disease? So I'm going to show you, this is the NAFLD conclave. I'll show you the NAFLD. And you can see over here, these are people on, you know, specific therapeutic and retrospective assessment fluctuations that were just captured in the course of care. Was made, these all settled down by, and this is with over patients. And what you see over here, you can have liver enzyme fluctuations 400-500 in rare cases, but the 100-200 range vary both AST and ALT. Next is the data for ALT, very similar slide. Alkaline phosphatase can get up into the range, all of the, you can even see that, particularly in those with compensated cirrhosis. Right? If you look in people with biopsy confirmed or in people with pre-fibrosis, you can even see bilirubin rise over 2 with. So the idea, these fluctuations reflect some sort of in the that the patient, sometimes you see these and they will settle. So the challenge then becomes to distinguish this underlying drug injury. So the basic principle of medicine is being do no harm is when in doubt, you always have to hope for the worst. You hold the drug, let the patient declare themselves and whether you want, based on how strongly you're responsible, you have to make challenging the patient. Next slide. So there are stats that have been developed by the This is in the context of clinical, is now sort of translated into clinical. So if you grade severity of the liver injury into grade 1, the criteria are shown that if your ALT, rises a certain limit, so this patient would about somewhere in the grade, right, up 5 of normal, and that you may want to download and keep. I find this extremely useful because this tells you sort of injury. Next slide. Then there are stopping rules. For people who start with normal, if your liver enzymes are above 8 of normal on a single test, 5 times upper limit of normal in 2. If you get into that 5 times, 3 to 4, you got to bring the patient back and retest. You don't necessarily have to stop, but what you want to do is that patient to come in a week from with an AST/ALT of 1,000, 5 and INR of 2.5. You've now committed the patient to it. Rare, but it can happen. So again, without boring you by reading to you, these are very practice management concepts. You cannot afford not, we blow frequently by saying the background disease. Many times it, and it is also, I think, important to create a registry of cases where you think a particular drug was involved. You can generate data because, there's always interactions. So the teaching point of this presentation really is liver enzymes are not carriers of the disease, always be possibility of drug-induced. And the time when you start a drug and when they relevant, each drug has a signature. So far with cerebral, real signature of drug injury, setting of NASH. There are reported cases and typically weeks to months. Often the patient has an intercurrent illness. It usually occur in people who already have or high liver stiffness disease. So those are some caveats back of your mind. So now I can take a couple of.
Stopping medicines. You hear me?
Yes.
Medicines. The last 2 drugs stopping we can understand, but should we be also in such a case?
Yes, because hepatotoxicity can occur after use, and particularly this is new. When you hold your drugs and then you can to prioritize between these 3, the most likely it would probably first statin 3 or SARO and be lower down because of toxicity. Typical statin hepatotoxicity, hepatocellular or cholestatic. Again, on statin for 5 years. Most statin hepatotoxicity occurs 1.5 years. So for 5 years, it would be mainly OCA and SARO rather. But if the injury, that's where it's a bit of a judgment call. So I will give you that. So if the injury is enough, if somebody has more than 8 times, the general rule of thumb, hold off any possible things clarify. But your point that 3 drugs in this setting have been for thinking about potential. Clearly, there are cases reported, and they are statin-induced hepatotoxicity is a concept. SARO really no signature yet, but early days in the NASH space, with, I think just when in doubt, it's drugs for a few weeks and then restart cortisol and see what happens.
When you do not grade 3 or grade 2 or any involved?
No, if somebody has, delay, then and reasonable probability that the drug is involved. To restart a drug is basically like case basis because no two are actually alike. So you have to think for a drug like, for example, it was only grade toxicity, the being saroglitazar or statin problem may not even have been due to OCA. So I would reintroduce the statins and the saroglitazar first, and then if patient nothing, then if you still feel needs the OCA on top of all of this, OCA, that's how I would approach it. So, and how severe the injury is at.
There's a question from Lucknow. Has the cap
we are running.
Can you take one at a time?
No, what I'm requesting is that we are already over time.
You can carry on.
Because it's 1 hour now since we are starting. If you could please resume.
Okay, all right. Fast. That's why I like having control. You can download these. They're established guidelines that are all. So next slide. So here are some take-home messages, please. Okay. Again, a patient who typical, and you have the additional information, the list, statin, saroglitazar, aspirin, patient is on a SGL, patient is core antibody negative, you see the liver enzyme rated, A1C is 10, 9, platelet counts are low, a patient has a spike. So I think a very clear profile is. Next, please. So patient is again to decrease, go back one. You're moving too fast. That's why I of my slides. Started on OCA and 15 pounds and tightened sugar, A1C down to 7.5. Next slide. Patient returns in 4 weeks. It now has edema. He reports reduced once a day. He's really pretty much eating. Diabetologist increased, but now he has ascites. SAG is more than 1.1, 210. You see his electron here, and 1.3. MELD is 4. INR and bilirubin still not. So why has the patient compensated? Induced hypoglycemia followed by glycemia, OCA, hepatotoxicity, starvation. Can we poll? Okay. OCA hepatotoxicity. Okay, keep going. So typically with OCA hepatotoxicity, in the setting of NASH, you would expect hepatocellular injury, stasis. So bilirubin 0.1, AST changed, alk-phos not that different. OCA hepatotoxicity. This is not OCA hepatotoxicity in the setting. Next slide. So if you will probably go back one. So if A gap, you'll see a substantial in this patient. An M gap is well over 15. Next. So this has ketosis, probable ketoacidosis, GLT2 inhibitors. Inhibitor-induced ketoacidosis, entity that is characterized by acidosis with low blood sugar. High blood sugars, your sugar can be normal, mildly elevated, and you diagnose A gap and positive ketones. Just a teaching point over here. And is one of starvation. What happens is when you tell your cirrhotic lose a lot of weight, because if you don't lose weight, you will not be a transplant. You have cirrhosis. They go starving themselves. When you starve rapidly, you don't burn fat, you burn muscle. Over here, there are many things, liver disease too, and the starvation response is a part of that, and which is of this slide. And you start, and when you start burning muscle provides a lot of reserve that buffers what the liver can. And when you take that away, you patient into decompensation. This was established in the symptoms for NASH, which was the Gilead, where the patients who developed clinical, all majority of them right before the decompensation, and that was due to worsening sarcopenia. Next slide. So muscle mass is critical. That's the teaching point. And again, you can download these and look at your own, leisure. But very much a muscle liver, so that the muscle can provide lot of functions that the liver normally. Next slide. Basically, there's the emerging of metabophenotyping based on the distribution and the distribution of adipose, which, as you can see over here, top left, if you look in normal people, this people probability of diabetes, coronary artery disease, hand grip, inability to falls. Now, if you go to normal muscle composition, there's a modest increase, but volume decreases. You can see there is risk of diabetes, coronary, and your risk of other falls starts increasing, and you lose muscle volume, intramuscular fat. That has a file of outcomes. So movement is an important part of the, and we need to pay attention to maintain compartment. Next slide. So in cirrhosis, we did, instead of starving the patient, we make sure they get 1-2 grams per kilo per day. Even if they have a little bit of this patient did not have. So people who have more advanced disease, who are is frequent small feeds, avoid constipation, depression, and manage it. And they're really been approved for this indication. I think that's it. Next. Thank you.
Thank you very much, Arun. Excellent cases and points that you've got. Maybe we have time for 1 or 2 questions. Dr. from Jaipur has an interesting question. We all are aware of the increased cardiovascular risk in NASH. Is there any evidence that drugs, OCA, these interventions reducing cardiovascular mortality in C? What is the information there?
So the answer is no. You know, a cardiovascular outcomes, so that a specific drug vascular outcomes, you have to study a few thousand patients for several years in a control, and we just don't have a set yet. Now the OCA is still going on. It has to be, and they are it. So this will take another year or two for OCA. Saroglitazar is much earlier in, and to date, to be absolute, the outcomes data are still lacking. From ICON-D, you can generate real-world data on cardiovascular outcomes on saroglitazar and compare them to matched controls.
Thank you.
Yes.
Maybe before we hand over to the chair.
A quick point. Arun, you select cases to drive home the point. Just to sort of clarify for the 1,000 plus people who have logged in, it was obviously cirrhotic and OCA don't have data. And the combination of saroglitazar to drive home the points of the lipid this thing of combination. So if you just like to make before
exactly, they're absolutely right. And not only are you right, fortunately, in the real world, already done by physicians at the time. Okay, so the ivory tower here and say evidence-based medicine, but the reality are already mixing and matching kinds of things. So the point of all of this is discourage people from jumping drugs at patients just because they're available. More cognizant about not only what, but also what there are gaps in knowledge.
That was wonderful.
No, thank you. A little overtime, but I thought on drug liver injury frequently.
No, can I make, in fact, you know, which we see in clinical practice is this combination of sarcopenia. I mean, in the sense that cirrhotic alive, he has stopped it, but you know, the progression of sarcopenia, diabetes with NAFLD. I thought that, you know, you had a very charitable mood offered that you session for us on sarcopenia part of it. I seize this opportunity on behalf of people that if we can have one of them, we'll talk about nutrition and sarcopenia.
Yes.
Is that okay with everybody?
Happy to do it. I think sarcopenia is a hot emerging topic in.
Yeah. We move on. I think the doctor see you, so I'm taking the ahead on your behalf. We move on to the presenter, and this is going to be Neeraj Saraf. And may I request and Dr. Krishnadas to others will all be there. Hi. So for those of you who Neeraj is actually a very eminent neurologist at the Medanta Hospital, extensive experience in all, but also transplant hepatology. He was an excellent speaker as well. Wasting much time on your behalf, may I Krishnadas and Dr.
Yeah, I think Neeraj, you can start have the discussion afterwards.
Okay. Thank you, Dr. Chaudhary. And I think everyone will agree it is difficult to speak right after Professor Arun Sanyal. So I'm going to be discussing two short case snippets, and these we see in our day-to-day clinics. Can I have I'll do which you know that NASH may coexist with other liver diseases, and I'll try to give as well. Can we have the next slide, please? So this is a photo. He's the businessman, and he had recent diabetes and was taking pills for that. It was told he is obese of 31.2, history of alcohol or smoking, and there is no known family. So he presented to fatigue and elevated transaminases for about a year. This is the time when he was diabetes and a recent hepatitis B surface antigen report. So basically, obese, diabetes, and coming to us with HbSAg positive report. So his trans are elevated, 88, and albumin is normal. Albumin is he has dyslipidemia, 88. HDL is low at 30. HbA1c is 5.8, so he's diabetic. So we worked him up further for his B status, and HbE antigen negative and body positive. His 7,600 IU, and the other viral markers like were negative. Because he had and he had hepatitis B, which showed a grade 2 fatty, and a fibroscan was also done with a high cap and liver stiffness 9.8. So we have a gentleman who has hepatitis B, a low viral load, but high, and he has metabolic fat on fibroscan and ultrasound. The expert panelists here, Dr. Mudigan, what do you think is the next? You have to unmute.
Yeah, you've highlighted a problem we face in clinical practice. We have risk factors for metabolic disease, we have fatty liver on an ultrasound, but etiology like hepatitis B or C. So you treat one first and treat the other altogether. Now, if you go by guidelines, hepatitis B may require.
Would you like to investigate any further?
Yeah, I think in this situation, which is contributing to the liver disease, is the best way to go.
Yeah, that's right. Next slide, please. Biopsy in the patient, and the biopsy showed there was steatohepatitis balloon, on the HE stain, and you can see there's a perisinusoidal fibrosis, zone 3, suggestive of so this patient had NASH with fibrosis. There were no features of chronic hepatitis, like ground glassing or any port. So the NASH with really no evidence of chronic hepatitis. Next slide, please. So I think I'll skip here. So we have a patient who has NASH. He has hepatitis B. If you go by the treatment guide, PASL or ASLD, liver enzymes are more than 2 times 2000, so he should be treated. The question is, what are his high liver enzymes? Is it NASH or is it hepatitis B? He seems to suggest that it's probably NASH rather than hepatitis B. Your views on this? How would you patient treat him for only NASH? Or?
does need treatment, lifestyle modification, therapy for NASH. Guidelines, one would consider indication for treatment for with hepatitis. We all know that these keep fluctuating, moving up and down. It is above the threshold, the possibility that it might go up remains. And not your most sensitive criterion about hepatitis B related injury. May not have florid evidence, but I am not sure the contribution to the hepatitis B. So I prefer to treat him for both.
Okay, can we have the next slide? So his final diagnosis is NASH. He has chronic hepatitis B, infection or hepatitis. I think that is next slide, please. Maybe we can take a vote on this, on what everyone thinks they will do in managing this patient. So manage NASH and hepatitis B both. The second is only with antivirals. Manage NASH only and monitor DNA and LFT. And option is manage NASH, repeat liver biopsy. Can we have? Okay, so most people with you, sir, that manage NASH and hepatitis. I think that maybe we can monitor the DNA. So actually, I did not treat both the things only for NASH, and I've actually kept hepatitis B. I don't know, again, like right or wrong, so I'll probably follow him up for a see if there's a rising DNA. Probably the safer option would be, maybe treat him for both. Professor Science, from you.
I do agree that it's hard to sort of separate. But the good news is, in the disease, you have time, right? Potentially do it sequentially. In the end, probably huge difference. But if in this, I would probably the patient's metabolic status and then reassess the patient. I'm not sure I would repeat the liver, but then.
Yeah. Well, I think just a quick point. I think Kaushal has a question for you, Dr. Kaushal Madan. Whether quantitative HbA1c might have helped clarify with antivirals or not. Although he would treat this patient with the hepatitis B. Quantitative HbA1c.
I don't think so. I don't think it would really make a treatment strategy. And treating both is probably not. We decided to treat and follow the hepatitis B. Daniel said, it's not advanced disease. And my only concern with hepatitis is that you don't know the endpoint. Any chance subjecting him to for many years, and maybe it doesn't. But yeah, that's the take. If there are no questions, we could probably move to the next.
Move ahead.
Yeah, next slide. So this is a 40 female who's in Gurgaon. She's non-hypertensive. She which is controlled. Takes a drink, but nothing significant. Bees with a BMI of. So she came to us AST and ALT. Most patients ultrasound with a report of a great fatty liver. Next slide, please. So we investigated her further for transaminases. Her was normal. Platelets were slightly low. The AST and ALT were elevated 128. GGT at 247. Bilirubin was not normal. HbA1c, she had dyslipidemia as well. Triglycerides of 217. HDL was viral marker. She had ANA to 160 positive. Autoimmune markers were negative. Was also fairly high at 20, and the ultrasound at our hospital showed a grade 2, and the radiologist felt there was some echo texture as well. So in view of fibroscan done, which again showed a high 300 plus and of 13.2. So Dr. Krishna Das, a middle-aged lady who has high AST, ALT, who's high autoimmune, ANA significantly positive, high IgG, also has metabolic syndrome and fatty liver. Step forward.
At first look, it looks like NAFLD NASH. Typical points. He has got several hypothyroid. ANA is positive. IgG is quite elevated. So I would like to roll out this lady and go ahead with our liver.
Right. Okay. So yeah, I think that's fair enough. So we did a liver, and so there was no evidence of hepatitis on the biopsy actually. Lobular inflammation, fat, and there was significant almost F4 fibrosis, Mason tripome stain. So there was hepatitis, and there was with advanced fibrosis. Now, if you look at the simplified scoring system for this, obviously this lady gets, but otherwise, she has ANA, which is positive more than 1:40. Are high, viral markers are negative, maybe fit into a probable diagnosis of IH. Next slide, please. So the final diagnosis is for fibrosis. Some findings in favor, but in favor AIH. So, how do we approach this patient? Dr. Samir Shah, can you, would you please
focus on NASH, although there is a possibility of autoimmune, it really doesn't suggest anything. So all the focus on management of NASH.
I mean, when I saw the autoimmune marker high, I was really expecting, histology in this biopsy. There was none, and the patient is clearly early cirrhosis with NASH. Next slide, please. So, audience poll at this approach this patient would be manage NASH. Both. Second would be felt manage NASH alone. Third would be manage NASH and maybe repeat liver biopsy. Option, she has a NASH. She maybe has hepatitis. I don't know if someone would think of. So can we have the voting, please? Okay, so I think everyone sort of agrees that we should manage NASH. I think few people think that maybe we NASH for now and maybe a liver biopsy later. So this is what I did also. NASH, I don't know repeat liver biopsy at some point. Any thoughts on whether we should monitor her for AIH as well? about AIH?
I think it's always reasonable to, but the reality, a lot of patients with NASH do have autoimmune markers. It actually triggers, often will have somewhat more histology. There was a patient from the NASH CRN about 10 years ago. Naga might have been the first. And what that, when the hepatocytes break down in the snippets are released out of the hepatic cells, get injured and die. Antigenic stimuli, and so as these cells get injured, you get fragments, etc., that lead to ANA formation. You have an autoimmune disease per se, hepatitis, but that's a actually seem to have more significance. So, it is this patient has NASH with cirrhosis. They don't really have AI, but typically, if you have AIA, it will rise significantly up to 10 times the upper limit of normal. That would be thinking there's a second process. Most patients with NASH on the will not have liver enzyme more than 200, 250. Will be below.
All of you. Hello.
Yeah.
Yeah, we're listening. Yeah, please.
Total IgG. We all do sensitivity of IgG regarding, and we got a biopsy of IgG. How often have we found autoimmune hepatitis?
IgG can be high in as well, but according to the for diagnosis, more than is what is suggested. Histology evidence as well. You cannot autoimmune hepatitis.
Yeah, I think where you find also is the titer of the nuclear antibody. Particularly if you have a speckled pattern and relatively low, like in 180, those are often setting of NASH. So the trigger for thinking about autoimmune liver enzymes over 253. If your ANA is 1 in 320, and if you have hypergammaglobulinemia, the hypergammaglobulinemia helps assess for much more of a tool to decide whether or not, rather than to make autoimmune. Biopsy has to be compatible with diseases, where I still find baseline biopsy quite useful. The histologic pattern of this is quite distinct from other liver diseases.
Okay. Can I have the next slide? So, just some learning points that exist with other liver diseases like hepatitis C or autoimmune hepatitis. NASH, rather than the apparent, may be driving the inflammation. And may, like these two cases, they appeared as autoimmune, but it's probably NASH which is driving this. A liver biopsy is useful situations to determine the dot and probably the outcome of these in view of coexisting. So that's all for me.
Panelists, can I question? So the flow of questions from the audience, I'm a flavor of the feedback. Quite a few from across the country wondering whether you needed for that hepatitis B patient. and quite a few feel that, simple therapy and the values were chosen, and if you are in doubt, it would have made sense to go ahead with alterations or whatever along with the viral treatment. So that seems one of the questions which are coming in. Question, and I remember, in fact, during my MD, we realized that 11% population have autoantibodies present, particularly so in women. Of the matter is that, yeah, it can sometimes issue just to know whether it's indeed contributing as the main cause for your ALT elevation and all that. So that could be a way to settle, but particularly thinking of a medicine which could be toxic. I mean, if you're thinking of steroids with a BMI of 30 with others, that's, I guess, where the comes in. But correct me if I'm wrong.
So
what are your views, Neeraj?
In the hepatitis B patient, like I said, is indefinite treatment. So I agree, it's safe and it's easy. It's indefinite, and yeah, you could avoid a biopsy. Helps you are a little more, sure.
Bayesian hypothesis that I agree. So the Bayesian hypothesis probability, if you have something so common, especially, I mean, almost like what it is, it's probably quite possible that with other problems will also have NAFLD. Maybe both will have to be in their own ways to an extent. Arun, what do you feel?
If I may add,
yeah.
The first case we were discussing, fibroscan value is not confirmatory of fibrosis and for NASH. I think a biopsy will give exactly what is contributing. So I think like this biopsy is
very interesting problem. The next presenter, if it's Koshi. Thanks, Neeraj. I think that was very interesting. Generated a lot of discussion.
I have Dr. Ajay to say that he requires no introduction. NASH group. He's PGI. Over to you, Ajay.
And at the outset, my to Professor Chaudhary and for making me part of this in our series. So, 10-15 minutes on another clinical aspect we commonly see in the, and that is about coming to you with cirrhosis. Up for all the etiologies turn out to be negative, kind of turning out to be a cryptogenic, and then we know that the NASH is the most cryptogenic cirrhosis today. So all cryptogenic cirrhotics are, or do we need to think of some other etiology? The learning point from I would be presenting. So start with the case. This 59-year-old from Chandigarh, non-alcoholic, no nothing significant, no history of diabetes, lipidemia, or coronary artery disease. Weight in last 10 years or so between 70 to 75 kgs. But now for the last 6 months, he had some weight loss of kgs, and he had altered sensorium, which was used as hepatic encephalopathy as a treating physician, this was around a month back, and then he was sent to for the further workup. He was normotensive on examination at presentation. weight was 66 kg and with BMI of 23.4. The Indian standards, I think earlier his 25, it was varying between 30, whereas now it was 20, fitted into the category of obesity.
We have temporary connection with Ajay. He'll get there. In the meantime, let me take the opportunity to all the viewers. Another format which we are using, conveying the same educational issue. This is case-based discussion. If you think that you like it, there is going to be a form at the end of this. In fact, at any time, and just let us know. We had planned 6 webinars over. One was for case-based discussions. People think that you enjoy this more. Have at least one more with other teachers haven't been able to cover. Is Ajay? Not yet.
So back, can we have some questions from?
Please, go ahead. Arun, what are you cryptogenic cirrhosis in?
Sorry, I was looking at something else. Can you repeat the question?
Cryptogenic cirrhosis problem, tendency for many of us, almost all is due to NAFLD. How do you see the scene in?
Yeah, it's a common perception everywhere. I would say a bulk of the with cryptogenic are due to NAFLD. The proof for that is because you take those patients, many of them risk factors, and if you transplant them, liver disease back. But there are probably patients, and I can't give you an exact number, out autoimmune types of diseases. So anytime you make a sweeping generalization, it will probably be a subset of patients.
But one of the which Ajay mentioned, I must appreciate your inputs on that. The person goes into developing cirrhosis, often loses weight, and that evidence of cirrhosis of NAFLD are often gone, muscle wasting and loss and so on and so forth. And the asking a person how much was your weight before and then calculating a based on that seems to be a good approach. Can think of using. It could have been NAFLD progressing. We're actually buying time for you to come back.
Sure. The slides visible now?
Yeah, it is.
So as I said, his BMI 23 and outside ultrasound had chronic liver disease. So we worked him. He had pancytopenia and his further lab normal renal functions. The enzymes were minimally elevated on the enzymes AST, ALT 68. His fasting blood sugar was again normal. Also normal because he came with weight loss. Biological workup, his virus, including core antibody, was, and he was negative for all other autoimmune DTGA as well. Again, didn't show any iron overload. Plasmin again was normal. We did a triphasic CT, evident of cirrhosis, shunts, and there were no SOS thrombosis. Fibroscan LSM of 45, 215. he had large varices, and that so a primary eval was done. Kind of scored him. He had a P of 7P around 10.1. So I just maybe the panelists, maybe so Dr. Murugan can take this and move further. At this stage, I have panel diagnosis in this gentleman. Cirrhosis or cryptogenic cirrhosis. Question would be maybe the other panelists can. Would you be going ahead with a liver biopsy?
As mentioned earlier, most cirrhosis that we thought of this lady, this gentleman, obesity, even by Indian standards, overweight, and other metabolic parameters. Gentleman. So if you look at the recent NAFLD, to give a diagnosis of NAFLD, look at the metabolic parameters that diabetes or pre-diabetic stage, hypertriglyceridemia, which yes, I think his triglycerides slightly elevated, and then his weight or his or the two other characteristics were IR more than 2.4 elevated. These two levels are not with us, and we should have an evidence of by any radiological examination or biopsy. So we cannot call him as NAFLD in this case. So with the diagnosis of cryptogenic.
Okay, and Dr. Murugan, this patient to a liver biopsy?
I don't think so, Doctor. I think the therapeutic for liver biopsy for this patient, I very much doubt you radiology on histology, and cirrhosis. But very unlikely, even if it is autoimmune or some other disorder, you may not find evidence. So I think therapeutic potential of a biopsy may be. So for that reason, I would.
Okay.
And I also more likely to be NASH, even though he has metabolic markers now, which in patients with cirrhosis. They lose, discussing earlier, they lose weight, all the metabolic. So it's very hard to find them, not in all. So I don't think that should be for a diagnosis of NASH cirrhosis.
Both the points are very well taken. The point made by Dr. Murugan is very important because the risk factors is more important than the factors when the patient comes. I told that he has been weighing between 5 kg and BMI 30, which by Indian Bs. So any BMI 5 to 30, we call it as class India, 23 to 25. So at present also he's overweight, 5 kgs of body weight in last 6 months. We do not know what were his and because lipids would tend to become with the onset of cirrhosis. We can't rely on that. Hypertension, we also know that the tend to become normotensive and the mean does come down with the onset of cirrhosis. Some of them do become diabetic because the serogenic diabetes, what we call, so the is more important. So the history of metabolic is important. So I think just I'll take another
minute. Ajay, just a minute. Question because it has come from Dr.
Right.
Who's a very eminent gastro friend. So she's asking, why did you need to do the fibrosis?
I agree. I think probably this was indicated in this patient and, who would have, large varices or anybody who has or ultrasound of cirrhosis for the diagnosis, you may not really require. So I think doing.
And one before you go to the next, Dr. Asif Iqbal What exactly do you mean burnt out NASH? I think you have answered, but if you can just reiterate the point. Murugan also mentioned.
Finishing the, I think, as I said, FibroScan will not diagnostic value here, but shown some prognostic value with a patient with a LSM would also be labeled as cirrhosis is not same with a LSM of 75. So I think good data which is available where people have the outcomes of cirrhosis, degree of fibrosis based on LSM scan, may that be decompensation, occurrence of HCC and other causes, people have done that. So there could be a FibroScan, other could be to look at liver by CAP. I think that you can idea of doing that. So I practice of doing FibroScan in this gentleman. To the second question out is, and which I will answer about burnt out NASH. So let me go 5 minutes and finish this, discussion. Some questions for the audience as say cryptogenic cirrhosis, which means extensive evaluation you had to do, already done, and you have ruled out all causes. And studies have shown the prevalence of within from maybe around 5 to 30%. Practice, I think 15 to 20% are cryptogenic. And if you look at the disease of cryptogenic cirrhotics, NASH is top on the list. But these are the other causes which have been in literature, and some of them are may not really come out with history of alcohol, occult alcohol abuse, occult Hep B or anti-HPC4 was negative in this. Occult viral infections have been impacted. It could be some uncommon viruses, still don't know. Burn hepatitis is another, ability in them, especially in a female autoimmune disease, and is there, and if the enzymes are normal, I think the burnt out autoimmune hepatitis could be celiac, and some of the alpha-1 antibody abnormalities have been implicated. Data coming in about the LAL acid lipase activity being responsible for cirrhotics. So I will show you again some literature on this. When the the diagnosis started being earlier study, this is one of the studies from Australia, that if you want to make a diagnosis, you must show histology and inflammation of steatohepatitis. Another elegant study by Professor Sania, which again said, which compared cirrhosis with the hepatitis, that once you have excluded all of there is no alcohol and you have hepatitis, so steatosis, inflammation, you can call them as NASH. But the problem is, I think, which what happens is that once to high fibrosis or cirrhosis, patients can lose on fat steatohepatitis, and this the sinusoidal capitalization cirrhotics, and there is impairment of the lipoproteins into the liver, so some lipogenic from insulin because of the photosystem is happening. So because of that, I may not show you evidence of steatohepatitis, and this is what about NASH or burnt out cirrhosis. So, but then the same study by Professor showed us, and thereafter there's a lot of other these patients with NASH cirrhosis, higher metabolic abnormality, higher BMI, hypertension, lipidemia in comparison to disease, and because based on this started using these markers for NASH. If you had a or diabetes or dyslipidemia, you have ruled out other causes, we start of NASH, and even some of the guidelines including our own, we suggested that if you have ruled and alcohol and overweight or obesity or central obesity with additional the metabolic risk factor as NASH cirrhosis. Even if you look at the AASLD EASL consensus guidance, which years back, and this is what I last pointed at too, they say you have to have one thing, you have to have current histological evidence of steatohepatitis. So in the man, we do not have a current previous histological evidence of steatohepatitis, though he has been obese. But then to call him by the practice guidance, I think probably would be difficult. NASH cirrhosis, and even if metabolic risk factors, at the best, cryptogenic cirrhosis, which was suggested also. So this again, 2 minutes, I would like to finish by this particular study, which has come from Thuluat's group, and which back in J. Hepatol, analyze a large number of database from 2016, and what they have shown, understanding of this, that how to make a NASH cirrhosis based on the other factors, and how of cryptogenic cirrhosis, things became clear. Over the diagnosis of NASH has gone up to 16%, whereas cryptogenic cirrhosis has come down %. And in this paper, the patients with cryptogenic cirrhotics, which I said they were all listed, and then they were comparing the clinician had labeled them as cirrhosis or NASH based on average or other parameters. Patients in cryptogenic, 11,000. Now, patients with cryptogenic diabetes and obesity and other factors. But look at this, patients had higher diabetes, obesity, more females, and risk of HCC in compared to the cryptogenic variety. When they divided or stratified them based on obesity, for within the NASH, even you were, which means your BMI less than 30, compared to cryptogenic cirrhotic, your diabetes were more than double. The chances of HCC, your female, and your age remains there. And this was true even when they were diabetes. So if you have cryptogenic, you had a patient with cirrhosis, had no, and when they compared with the obesity, causes of obesity were much more in the comparison to the cryptogenic. What they did was around 1 lakh in the UNOS database with the 11,000 people with NASH, and they came out with these, multivariate regression. These are the risk factors which, risk for having NASH cirrhosis rather than you should not be labeling them as cryptogenic. So I think based on this data, what they suggest that the cryptogenic cirrhotics, overweight or obesity, could also be, but what is required is a diagnosis of steatosis or steatohepatitis at some point of time before you kind of label them as. So my learning points from this case, I have around 10 to 20% of our cirrhotic. We do understand that the NASH etiology in them, but this may not be etiology of cryptogenic cirrhosis. Patients with those who have obesity and may not be NASH cirrhosis. Patients, those who may be obese, be diabetic, but they could be truly chronic, and today we may not have etiology in them. So, in conclusion, would be that the NASH cirrhosis, cryptogenic cirrhosis, may not be taken by animals. So I will now stop, and I'll ask Rishabh organizers to put up my for the audience. Question number 1, please. So I think it was as per the Practice Guidance 2018, diagnosis of NASH cirrhosis can be made in having no significant exclusion of other causes, alcohol intake, exclusion of other causes, obesity, or no alcohol of other causes and presence of 2 or more factors, or no alcohol of other causes with current previous histological evidence of steatohepatitis. So I think let's have the polling. I think what the results show, 45% are saying that you a current or a previous histology steatosis or steatohepatitis, you call somebody as NASH cirrhosis. 7% do feel overweight, obesity with risk factor or maybe just 2 components of, and if you have excluded all other causes as NASH cirrhosis. I think to me it looks fine. I think maybe we can hear from the panelists and maybe from.
What does the ASLD show?
You
You started off by telling that according to guidelines.
Yes,
so that is the Bible. What does the Bible say?
That's the number D, that you need to have current or the previous of steatosis or steatohepatitis.
Okay. So parameters alone doesn't matter.
Yeah, this is what, as I said, the guidance. Have opinion from the panelists and.
No, and
any Arun, any of you?
I thought in practice would accept that the presence of metabolic risk factors, no alcohol, most likely mean cryptogenic cirrhosis. The D criterion which has been introduced in SLD now is very difficult to meet, except in people for whom we prospective records. Most of us and then all data date back not more. So getting usually not found. Histologic evidence of steatosis is extremely uncommon. So for practice, it will be difficult to meet the ASL in India at least. And C, metabolic risk factors, habitus, things like that would probably. And at some point, Ajay, it's so important to differentiate the two.
That is exactly the point. And having diabetes, you obviously, whether you call it NASH cirrhosis, so you need to treat these other factors. So the diagnosis, area is really for study that you want to do. So there, yes, of course, you need to define. But otherwise, all the patient presents with, even if he has hypothyroid, you need to treat the patient as a whole, not just.
With Abraham more.
I think
Arun, yeah, your comments, go ahead.
So, the reason this is in the ASL way is exactly as Abraham said, to give somebody, it's about precision and your label. But in your clinical practice, the reality is accept that if you have 2 or more, if you exclude all other causes, somebody has cirrhosis and metabolic risk factors, they get classified as cirrhosis, most likely due to fatty liver disease. The reality is both are correct answers for day-to-day clinical management.
Maybe I just thought, I think the same paper where you compared the Hep C products, once you are child acirrhotic NASH versus a child because of hepatitis C, the natural rate of decompensation time would differ, but and NASH cirrhosis may have little, their child age. Once they go into child bleeding, then probably it won't matter. So is important to know?
For Hep C, is obvious. A positive PCR. For cryptogenic first, people who truly cryptogenic, you have to do a biopsy. There is no evidence of fatty liver, and that study is done. So yeah, probably a huge difference. People might have a little higher incidence of carcinoma than NASH. Rate of decompensation to 4%. In now, other studies have shown that. I'm not sure it makes a personally. Cirrhosis, you have clinically compensated tools to identify people with compensated cirrhosis, identify the risk of decompensation. Sometimes patients just very rapidly. And one thing I've noticed, which is different between NASH and hepatitis, is the NASH patients, they get a little bit, and then within a couple of months, they're deathly sick. I mean, they are in the ICU, all kinds of problems. Whereas with decompensation, it follows sort of a more, they get the ascites, there's sort of a progression. Whereas the NASH patients, they stay stable, but when they really just fall off the cliff. Just sort of my clinical observation side.
Okay, so on to the next question. Okay, so the next question is to hepatic steatosis, steatohepatitis with cirrhosis in patients with NASH. Choices again 4. One, both steatosis and steatohepatitis can decrease. There is a decrease in both steatosis and steatohepatitis. Nothing happens to steatosis, is always decrease. Nothing hepatitis, but steatosis always decrease. We have the voting. Okay, 61% have said both steatosis and steatohepatitis. I think that's the right answer. Can decrease, and then I think sometimes it may become difficult to make a diagnosis of NASH cirrhosis. Because even if you do a biopsy and the evidence of hepatitis, I think how do you then fulfill which is about the diagnosis of NASH cirrhosis as based on. So now again, maybe we can have some discussion on this. And again, the cap was normal, so to have fat even on had done that. So now him as NASH cirrhosis, cryptogenic. He had only one metabolic risk factor, so obesity for say last 10 years. That debate continues here.
Thank you very much. I think there's a questioning what is the point in to distinguish, but nevertheless, it was very interesting and it drove home a very point that all cryptogenic NAFLD related, and once it's probably very difficult to go back and say how it all happened. Of obvious parameters. Go back and have this slide switch. I have a few announcements to make because it's 6:30. We have 2 hours, and the overwhelming I'm getting, Dr. Koshi, we are 2 of us are the chair. Overwhelming feedback that I'm getting, 1,500 people, they seem to still mange more. That they said that we want more, in the sense that some have written that this is something they seem to want more in lectures. So in the our audience want request, and again on behalf of you request, be a little kind to us and have some time. I must tell all some of the learning points which we had enumerated, 9 or 10, Arun had enumerated, covered all of them. And in fact, the next very important case we were to discuss to do with a person who has developed fitness and has got a obesity, BMI more than 30, and to bring his weight down, and his head. So what are the measures and how do we manage? Several others. So my if we could today, it was a case that Neeraj had to do. Let's keep it on hold, build up as to what are the strategies, let people a common clinical problem, and all of you agree then we should possibly again when we are a little more fresh and is that okay, Vivek?
Absolutely. I think everybody's relishing the format, and I think the time over them, not rushing over the learning, probably one of the most the format to let the messages sink in what the audience is enjoying. So let's easy rather than meet targets and let's do it in 5 minutes. No, I think it again.
Yeah. And of course this problem of sarcopenia that needs to be
right.
Well, a suggestion I have is also to for all the attendees try to think about some way to this really is impacting how thing, because ultimately for a bunch of us to get here and each other would love to do that. We can actually tell and reminisce about old times. The point is for the large to actually help improve or change the way they practice. You can think about some potential
sure.
Whatever it is, if practice is indeed, that's when we know that we have succeeded. How to do.
Absolutely. Tell you that there is a feedback form, everything, but one particular needs to be, can I just have it? Yeah. So please, question number 2, what would you think to have or attend more of series in the case discussion format? How do you rate it? So kindly give your, go strictly by the audience feedback. The next date is of course 20th September. But more importantly, learning points which today we learned, Arun Sanyal and others, reporting of a fibroscan, not to write F3 fibrosis, but to write, and I think that is a very important. I have, there are regress from 15 or 7 because it was an acute hepatitis, and it's very embarrassing when that means the previous doctor what he wrote. I mean, it's not wrong or right, it's a question. So that's at least one very important lesson, Arun. And the second point, do no harm. So whenever there are medicines involved, be cautious. Heavens won't fall if you withdraw medicine. And the fact that even patients, they have these ups and downs of the, I mean, what in hepatitis C used to be phenomena. So I mean, apparently what something like that, the peaks and troughs, and so that's a very important point. One of the points which should be a take-home message: all patients who have another etiology, look a little closely. If the stakes are not too high, treat, because obviously one is associated with other, the NAFLD part of it, but and the autoimmune marker. And I think from Ajay Daseja's talk is that cryptogenic cirrhosis, surprised that Ajay said that only 10% of his patients are cryptogenic. In practice, I find that it's about 30%. I mean, correct me. It depends on how deeply you have stuff. But yes, every may not be a NAFLD related cirrhosis. We dissect through and what could be the implications of prognosis and so on and so forth. Is that okay, Dr. Abraham Koshi?
You have summarized it excellently, also good. And I think audience has repeatedly said based discussion because they relate to it much better than a lecture.
Thank you very much, but may I request consult my colleague and the organizing to pose the vote of thanks, please. Doctor, yeah.
Thank you. Professor Dr. Arun Sanya, Saraf and Professor Ajay Duseja presented and there was such a we enjoyed a lot to our respected model. It's a matter of more than 1500 logged in and really nice to keep them of 1500 delegates. We have 3 more webinars after webinar on 20th September. So just mark. Your feedback is very important. As we will have to go by feedback. So please give your feedback. And I want to say big thanks to our advisor and executive committee. So thanks and to the sponsors of and event partners for NIMTA. Much. We will meet on 20th September.
Thank you.
Bye bye. Thank you very much.
Bye bye.
Thanks,
Bye-bye.
Arun.
Bye.
Bye, guys.
Thank you, Dr. Murugan.